Hello, everybody. So very important topic, carboplatinums in TNBCs. So what we know about carboplatinums in TNBCs, especially for the NACT setting, is they have shown consistent impact on the PAT-CR rate, however, at the cost of increased toxicity. And yes, the adherence to chemotherapy becomes difficult. There is lack of clarity on the long-term benefit, and there are a lot of conflicting impact on the survival figures in the studies. We also don't know for what patient group are they most suited, young versus old TNBCs or weekly or other schedules. So with these questions in mind, the year 22 brought in some very important study. The first is the addition of platinum to sequential taxane anthracyclines, NACT in patients with the triple-negative breast cancer, a phase 3 randomized control trial from TMH. So this is the trial scheme. The TNBCs patient with 1% cutoff of ER/PR were taken. They were randomized in the platinum, that is a paclitaxel, and followed by the standard our anthracycline cyclophosphamide and the control arm. The stratification were based on the menopausal status and also the clinical stage, operable breast cancer and the locally advanced breast cancer. Now the platinum, the schedule here was the paclitaxel was the weekly, pacli 100 milligram per meter square with the carboplatinum AUC2 once per week for 8 weeks, followed by the doxorubicin or epirubicin or in addition to the cyclophosphamide. So then followed by the surgery around 3 to 4 weeks later, followed by the radiation therapy. So this was the primary, the event-free survival was the primary endpoint. Unlike the studies in the past, where the usual the usual NACT trials have taken primary endpoint being the PAT-CR rates. And yes, there were secondary endpoints of overall survival and the PAT-CR rates. So the capecitabine was not used after the surgery because those data was not there. Follow-up was every 6 months, which I feel is a slightly larger follow-up duration that we do after surgery for these group of patients. So the study accrual was from the April 2010, and 717 patients were included in modified intention to treat analysis, and the median follow-up of 67.6 months. So coming to the patients and the tumor characteristics, fairly balanced. The median age was 46 years, and yes, we know for the TNBC patients, we usually see young patients. Predominantly, patients were young, less than 50 years was 68.8 versus 70.6%. Predominant patients were pre or perimenopausal, 58.7 versus 57.9. BRCA status was not done in this particular study, but yes, the family history of any cancer was not there in majority of patients. So most of the patients had advanced stage disease that we usually see for the TNBCs, the locally advanced disease, the lymph node positivity, and yes, the larger tumor size. 99% patient had grade 3 in the both arms. Now, coming to our favorite endpoint for the NACT trials, the PAT-CR rate, we do see that the addition of carboplatinum does make a difference and increases the PAT-CR rate in a meaningful manner with a difference of 14.2%. However, if we see the data in detail, we see that the difference is limited to the benefit of addition of the carboplatinum is limited to the age group of less than or equal to 50 years. And you can see by the graphs, both the age group of less than 50 years as well as age group of more than 50 years. In the age group of more than 50 years, the PAT-CR rates are low and addition of carboplatinum does not offer any meaningful benefit. The important endpoint of event-free survival, and here the carboplatinum again makes a difference. The 5-year event-free survival rate in ITT arm was 70.7 compared with 64.1 with a p-value of 0.08. And again, when you see the data as per the age distribution, it is largely limited to the less than 50 years of age group. Here, the 5-year EFS 74.2 in the platinum group compared to 61.7. And yes, in the control arm of the more than 50 years, it's actually the hazard ratio becomes 1.309. So platinum is not helping there. And this is what you can see from the subgroup analysis also. For the patients who had operable breast cancer or the smaller T size or the negative lymph node, the sample size were quite small to draw the meaningful conclusions. Now, when we come to overall survival, again, the platinum addition helps. The 5-year overall survival was 74.4 in the patient given carboplatinum compared with 66.1, and this value was statistically significant with p-value of 0.02. But again, the benefit majority limited to the less than 50 years age group and not to the more than 50 years. And the overall survival subgroup analysis also is somewhat like EFS analysis. Now, important point is patients who achieve PAT-CR rate, they have good EFS at 5 years, 85.3 versus 52.2, and this parameter is irrespective of the age, of the cutoff of the 50 years. So PAT-CR achievement is very important. Now, somebody will think that if the patients are elderly, they are not able to tolerate the chemotherapy, maybe the treatment adherence is one of the problem, and that is why the patients are not able to achieve the same results as the young patients. Side effects were there, the hematological side effects with the platinums, but they were not like in a major way contributed to any treatment attrition or the poor compliance. So the treatment compliance and the toxicities were not different in the younger and the older patients. So the authors concluded the addition of carboplatinum to the sequential taxane, anthracyclines, NACT significantly improved overall survival and tends to improve event-free survival among patients with operable and the locally advanced TNBCs, but the benefit seems confined to the younger or the premenopausal patients, in whom there is substantial significant improvement in the EFS and OS. Another conclusion is increased PAS-CR with carboplatinum is predictive of EFS and OS benefit in younger patients, and lack of improvement in PAS-CR is predictive of lack of EFS and OS benefit in older patients. So, but the precise reason for the interaction is not clear. Weekly carboplatinum helped to increase the compliance and reduce toxicity. So maybe if we want to use in our practice, more than the 3 weekly carboplatinum is the way to go forward. So the important thing is that there was a consistent impact over both EFS and overall survival. It was one of the first phase 3 trials with NACT carboplatinum with EFS as a primary endpoint. Like I previously said, we usually have PAS-CR as primary endpoint. But again, lack of clarity on why benefit limited to the young TNBCs. Are they dealing with the different disease biology at the different age groups? We know that in the young, there could be BRCA, HRR, HRDs, basal types, and yes, predominantly maybe luminal non-basal types in old. Now, important thing is, if I'm sitting in my OPD and somebody 75-year-old comes in, sometimes I tend to give Pacli carbo. Will I be able to use that in that group or not? So that is also one of the clinical questions that I have. The other trial was long-term efficacy and safety of addition of carboplatinum with or without veliparib to the standard NACT in TNBC, 4-year follow-up data from the brightness, which was again a randomized phase 3 trial. Now, again, a very interesting study, 3-arm studies, where paclitaxel versus pacli plus carbo versus pacli plus carbo plus veriparib. Again, they have used a paclitaxel or 80 milligram weekly regimen. Now, 12 doses in up to 16 weeks. That means if the patients are having side effects, they allowed delaying of the treatment, due to which they were able to complete all the therapies. And the carboplatinum AUC 6 was used in this particular trial, which I feel is very strong regimen. Now, initial results were published in 2018, where it shows that the carboplatinum addition to the paclitaxel improved PAS-CR rates. No further improvement by addition of veliparib, however, at the cost of increased toxicities. But yes, now let's see the long-term EFS, long-term OS, and the rate of second malignancies. So again, median age of around 51 years to 49 years, and 50% in the more than 50 or less than 50 years. We also see a lot of elderly TNBCs, like you can see the upper limit being 79 years or 76 years. And they also did the BRCA analysis. Now, the stratified analysis of EFS with median follow-up of 4.5 years favors addition of carboplatinum. So the pacli carbo versus paclitaxel in the post hoc analysis, the HR was 0.57, favoring addition of carboplatinum. However, in the overall survival, we don't see these kind of figures. So yes, but in the event-free survival, we do see. Now, people thought that maybe because we have veliparib, we have platinums, there will be more second MDS, etc., but that was not the case here. Also, what is important was the patients with the PAS-CR has improved EFS. So achievement of the PAS-CR is very important compared to those without PAS-CR, regardless of the BRCA mutation status. So you can see from these 3 graphs that irrespective of the BRCA status, if you are able to achieve PAS-CR, it might convert into a longer event-free survivals. Now, important studies again, CAL-GB403, they are slightly discordance with the CAL-GB4063. Neoadjuvant paclitaxel with carboplatinum plus minus bevacizumab, and so you can see the 4 arms here, and this was 2 by 2 factorial design. So what is interesting here is that again they showed that good rates of PAS-CR rate with the addition of carboplatinum. However, the trial was underpowered to determine survival benefit, and yes, there were no major impact of carboplatinum and 3-year EFS or the 3-year overall survival. But now we have again the long-term data. At a median follow-up of 7.9 years, the long-term outcomes were not significantly improved with either carboplatinum or bevacizumab. However, patients with PAS-CR had a significantly higher 5-year event-free survival and overall survival. Now, why there is a difference here? So this is a very important slide to show why there is a difference. What could be the possible reasons? So we have long-term data of the brightness study by the addition of carboplatinum, which shows benefit, but not CAL-GB4063. Now, important part is, in the brightness study, patients were allowed to complete all treatment, but the delay were allowed. In CAL-GB trial, what happened, that the delay of the dosing was not allowed. Patient actually had to skip the doses, and that was the problem with the CAL-GB study. Patients skipped the doses, that also converted into the inferior long-term survivors and also in the PAS-CR rate. Now, they also did an exploratory analysis for CAL-GB4063 trial, where if the patients were able to adhere to the dosing, There, the addition of carboplatinum increased past CR rates, and also there was a trend for improved 5-year event-free survival. So whenever you add carboplatinum, make sure that the treatment adherence is definitely there. Another important meta-analysis to shed more light on this question, the addition of carboplatinum to neoadjuvant and adjuvant setting in chemotherapy in TNBC patients improves overall survival, and individual participant data and trial level meta-analysis. So this was extracted rather than the actual individual patient records for the IPD analysis. So 8 studied overall, 6 studies for the NACT part, overall 2,425 patients. So you can see again the primary endpoint being all the past CRs, and that is why they were not individually powered enough to detect the EFS, DFS, and overall survival. However, when we do a meta-analysis, the pooled analysis definitely shows that the DFS improves after the addition of carboplatinum to the neoadjuvant or the adjuvant chemotherapy, with the significantly improved figures of DFS by 40%. And this has been shown by both the trial level data analysis as well as the exploratory IPD analysis. Similarly, for the overall survival, again, a pooled HR of overall survival with the benefit of the addition of the carboplatinum. So we do see that yes, the addition of carboplatinum in this particular meta-analysis improves the DFS as well as the overall survival. Toxicities were also seen, predominantly anemia and thrombocytopenia were higher in the carboplatinum group. So combining all these 4 studies together, the meta-analysis further consolidates role of carboplatinum in NACT for TNBC with positive impact over both DFS and overall survival. Data supported at patient level and trial level data. There was another meta-analysis presented in SABCS in December with the similar outcomes. Benefit is derived only if there is dosing adherence. So maybe the weekly regimen is the way to go forward. However, we need to see what is the impact, why is the impact limited to the young or the premenopausal females. But what we understand is that the attainment of PATH-CR is important, and the impact lies beyond the BRCA subset of the addition of platinums. Thank you.